Hi everyone, it's Matthew McKenzie here again. And if you don't know, I usually report and create content basically on unpaid carers, um, usually focusing on those caring for someone living with long-term mental ill health. And I often also create content regarding inequality, the focus on raising awareness of equality. And I've now started focus on promoting information, education and awareness regarding anti-racism. And this particular presentation, I would say, isn't much different. You might not have heard of PCREF. I'm not going to go heavily into it. If you want to go into that more, then look into the description of this video. There'll be links to other videos that I have that goes into PCREF, which is the Patient Care Race Equality Framework. The main aim of this particular video is including unpaid carers in the Patient Care Race Equality Framework, hence putting the C, that means carer, into PCREF. So let's start. What do I mean by this? Now, before I continue, I should have mentioned I am heavily involved in PCREF. Um, I'm engaged with quite a few mental health trusts regarding that. I also currently chair the Triangle of Care Community Group. But it's not just about that, it's what you do outside those roles. And I do feel it's really important to, do what you're trying to preach. So I do go out into the community when I can and raise awareness and do some of the things that I'm actually going to mention in this video. So continuing on, what do I mean actually by putting the C into PCREF? Well, basically, you can see from this title, having care is at the heart of racial equity. So I'm going to break this down a bit. I'm not going to go heavily into the explanation of PCREF because there is a lot involved in that. I'm just going to touch on that just a bit, and then we'll move on to focus of why it's so important we have unpaid carers involved in PCREF, not just involved, but also holding to account and treating it as if it's a movement, which it actually is. It is a movement, not as just a set of, it's not just a framework, it's not just a set of policies. It's putting things into practice, but having the community also lead as well. So basically, I'm only going to really just describe this on PCREF. Basically, PCREF, which is Patient Care and Care Rate Quality Framework, is just a major opportunity to transform mental health services. But from where I stand, we cannot just achieve that race quality without centering carers as well. A lot of the focus obviously is on the experiences of patients, service users, minority people, global majority using those services and the historic racism, bias, poor levels of service, discrimination that they've encountered. But where does carers fit into this? Well, unpaid carers are not just ethnic, to be fair, although I'm seeing from an ethnic perspective, it's not just that, but they do hold communities together. Caring for someone expands. When you're caring in the community, others in that community learn from that. It forms part of their culture. Um, and going on to culture, it actually bridges that culture and those care systems. We can't just say that the health system get on with that, and the population just expects the health system to just do that care. That's not working. It's not affordable. So the idea really is we all need to care together. We all need to focus on what can be preventable, hence mental health. But we can't ignore again history. Going back to carers, the role of caring is invisible. And when you consider mental health, that's even more invisible. When you're thinking of unpaid care, you're thinking of someone perhaps washing someone or helping them along if they have mobility issues, but you can't often see that within mental health. So with unpaid carers, they're actually, especially mental health carers, carrying invisible emotional, financial, and advocacy burdens. And they, just to let you know, I'm not downplaying the important experiences of patients, mental health patients, and service users. And there will be some concepts that might annoy, um, and and I don't mean it in that way. Um, I am trying to again focus on unpaid carers. There are strong mental health survivors out there, and given the time, they will have plenty to say, and they should do. But we can't ignore the situations that there are examples where carers, minority carers, will struggle. And it's through advocacy, it's through financial situations and emotional situations. But going back to the patient care risk quality framework, it's not just about equity, to be honest. We must make sure that whatever those carers are going through, which is invisible, we must make them visible, must make them valued and embed them in this movement, not just to be consulted as an afterthought, like, what do you think of this? And how do you think this will affect you? And such as such. Even, I'm not expecting minority carers to get it right. We're not perfect, but it's important we're given a chance to have that voice because that leads to a form of power. And I will touch on that in a bit. So continuing on, let's focus a bit more about the hidden workforce regarding mental health carers. So across communities, and PCREF does focus heavily on communities. Unpaid carers, when you're thinking of cultural, ethnic background, they translate language and culture to a health system that isn't really built for them, but still tries to bridge that gap. But it can't unless carers from those communities are given the chance to help bridge that gap. They do this anyway, but they're not led to do that. They try and navigate health systems riddled with jargon, and they often may distrust them. They try to navigate those systems that they might feel unsafe and discriminatory. It's not often obvious to staff that this is happening, but past experiences may lead minority carers to feel that way. Carers from those communities often advocate during crisis and detentions. Now, this is where it gets a bit more tricky because often we expect the patient to do that, and that's fair enough. But when there's a lack of insight or they don't want to engage with services, usually the first, not often always, but usually you would start hearing from the family or perhaps the main care within that family or set of families from that community. And what's invisible, but not often all the time, is that carers absorb that trauma after inpatient admissions. But to go further, it's not just about the admissions, it's about the discharge. It's about experiences to those mental health services and health services as well, although a lot of the focus on PCREF is obviously mental health services. Hearing from carers, minority carers, but this can be extended to carers across the board. Some or most I would say that they feel excluded from care planning. It's almost as if they feel they've been dictated what they're meant to do, but at the same time not involved enough to know what they're meant to do because they've not been given that voice. And when they use that voice, they feel they're not being listened to, or perhaps misunderstood, or even worse yet, discriminated or shut out of that conversation. This now leads to forms of structural racism alongside their loved ones. We often feel, yes, the patient, minority patient, Black, Asian, continuing on, is experiencing structural racism. But this, remember what I said about absorbing trauma and experiencing those things, this can impact on families and unpaid carers. If this is a cycle that continues, then other things that will affect those carers will be burnout, especially if there's lack of support, lack of advocacy, lack of referral, lack of inclusion. Without a doubt, we feel PCREF, the Patient Care Race Equality Framework, must address racial inequalities for carers, not just for patients, not just for service users or people using mental health services. So how do we put that PCREF into that form of paperwork? Well, it requires a form of co-production. It requires data transparency. It requires cultural humility. And to prove that it's working, you need measurable actions on those racial disparities. Obviously, that leads back to data as well. So obviously PCREF requires a lot more than that, but those are some of those main things. And I'm trying to keep what I'm showing here fairly brief. I do sort of waffle on in my presentations. This is where it gets really tricky, unfortunately. When we're asking for accountability, when your organization, when I say organization, mental health trust, private mental health facility, it's who's asking those questions. Are carers actually being represented in governance? When I say who's asking those questions, I'm not saying just the Care Quality Commission or Health Watch or even your integrated care boards. And excuse me for the jargon, I will explain some of these in other videos as well. But carers are also meant to ask these things if they're involved in mental health services, or if they're in the community and they're showing what your mental health trust is doing with PCREF. These questions should be asked. So, are they being represented in governance? Are they being involved? Are they helping to shape those services, redesign of those services? Are those services measuring care experiences by ethnicity? And if they are, what's the impact on minority carers? Are we looking at those community-led solutions with carers? And I'm saying we're not always going to get things right, but given the chance, we can try and work together. Even if carers do get things wrong, they do feel that they've been part of that movement. And I will say this is a movement. It's not just policy, which can be a danger if we think it is just about a set of frameworks and policies. It goes beyond that. I'm not saying it's easy. I'm not saying it's easy, but that's my thoughts on it. The last thing, obviously, is when it comes to accountability, are carers invisible in those metrics? They may be invisible in reform, or if they are invisible in reform, that is the danger we need to avoid. So continuing on, this is where a lot of the work should take place that we know things are working. Now, I did mention earlier on, as of this making this video, I am working quite hard as I can in regards to trial of care and promoting the good works that is done for many years. I've been involved in that, but with change, we should take what is good and include that going forward. And when I say putting the C into PCREF, these are one of the tools that I mean, I'm not always correct in what I say, but I feel that is useful as I would say, a metric in some sense, or accreditation, or a nod of approval. The point of trial care, putting it simply, is that it has the clear model of inclusive of all in communication. So we have the patient, the carer, and the professional all talking and communicating in a triangle. That's fine, but now we have other frameworks. How do we include that? Well, it's usually built on information sharing. Obviously, with consent, we can't automatically assume that it's going to work for everyone, each case regarding the patient and care relationship can be different, but we want to work towards those standards. So information sharing, inclusion in care planning, care assessments, so we can measure support and include carers needs as well. Cultural understanding, and obviously that's focusing on the PCREF standards, emotional support. So therefore, with all these things and more, obviously I can only mention a few, PCREF information should formally align with trial care standards and vice versa with the explicit racial equality lens. I'm not saying it's easy, and there'll be times there'll be lots of challenges, but we're working towards standards that work and can adapt in time. So almost finishing up now. Mental Health Trust, what can they do well, this is my thoughts really, and I'm sure some of these things are being done anyway, but this video is aimed at unpaid carers and perhaps some professionals as well. So that way they've got something to refer to. So basically, I've been involved in quite a few NHS Mental Health Trusts. I do feel they should include minority carers into those steering groups. And the steering groups shouldn't be hidden. We should know what they're doing. If you have a mental health trust and organization, what are they doing? Who's on that? And it shouldn't be just patients and service users. Otherwise, we're not really including those voices of those that unfortunately can be invisible. The next bit, obviously, if you're including those voices, you should place this into data, and you should look at your data. I'm talking about patient records systems where there must be information about unpaid cares. I would find it quite odd if an organization is a trial of care on the trial of care accreditation and don't have any care data. Unless obviously they started out on that, I can understand, and it's trial care is flagged up if things are missing. This is now we're looking at PCREF. So there should be investment into community grassroots-led forums, care-led forums, patient forums, obviously as well, to show that we value them, that we're not just using them to get information. Now, this is a tricky one because obviously with the health service that they're asked to do more with less, there are cuts. So it's a very, very difficult challenge. But this is one of the things I think going forward it can be helpful. This just shows how the community can value services that feel that they have their wishes. Engage and co-learn with care centres on minority carers. There are care centres out there looking to see how can they incorporate the patient care race equality framework and triangle of care and get carers interested in those things. And this is where health services can go out into the community and say, this is what we're doing. This is something new. This is a movement. Despite all the challenges we face, we want to learn with the community and we want us to be trusted. I'm not saying this is a situation where there's some services are working very well and have earned that trust, but there are others out there they've had a history, a sad history of letting down or not really listening to those in the community. And a lot of this is down to training, but this must be done with co-production. It can't be siloed off. I mean, if staff really want to hear those voices, it is about power, whether it's patients helping to train or carers. And being culturally responsive to that engagement as well. This is one of the key things. Childcare is, as I know, is growing stronger. Many professionals out there can see the actual benefits of the trial of care and carers as well. You can't always expect an organization to hold itself to account if it wants to be trusted. That's how I feel. It will say, this is what we're doing. Do you agree it's working? Hold us to account on these things. We're not always going to get it right, but we're going to try and work to standards and frameworks. And we will seek to embed those trial care standards into our race equality plans, whether it's engaging with a carer or community or going further into service development or as I say, perhaps even policies as well. And help commission, I'm not saying just commission, but help commission culture appropriate respite advocacy, which is lacking out in the community, which is, it cannot go back to how can we fund community-led care forms or patient forums. Equality requires structural change. It's not just a symbolic consultation where you hold one event and you say, this is what we're doing, and that's it. It's more than just consultation. It's co-production, but it is further than co-production. There are a set of challenges to that, but also risks as well. I'm not saying it's easy to do, it isn't. So throughout what I've presented here, I've said that it is a movement. It certainly is. It might not look like that. And it's asking those who are in authority or those who are not in authority to take that brave step and take up the challenge. It is a movement. It's different compared to what I've seen before. There are challenges to this movement, as with anything. But it's people at the heart of this, it's communities at the heart of this. And if any organization is separate from that, then something's not quite right. So my message to those who lead on mental health services, I feel cares, they shouldn't be just an add-on, being told to get on with it. They are partners that work towards safe, equitable care. And to carers, your knowledge is expertise. Don't feel that because you're having to fight hard that you're worthless and useless and you're banging your head against brick wall. I've been through that and still going through it with my caring journey. Your voice is evidence because that evidence should be captured and should be used. Obviously, with your agreement, I understand that. But your lived experience is leadership, even if others challenge you to say that it isn't. And believe me, they will challenge you. PCREF is a chance to redesign power, which is, I feel, if there's anything taken from this, is how can we give power to others to help on this journey. And my last word on this is, let's put the C where it belongs, at the center. Just to note, I'm not pushing patients out of this, and I expect minority patients to have their say. But a lot of my focus is on, because of my lived experience, I can't speak for patients, and I shouldn't be doing that. But I do feel, from my lived experience, families and carers that are providing support do need to be included. Well, if you felt this video is useful, do give it a like. As you might know, the more likes on a video helps promote this video further on, and it helps educate others. If you like the content of this channel, do subscribe. I try and, if I can, put more content during the week. And let's say if you're watching, do look after yourself, and I'll see you again soon.